So I think the incidence of hypoglycemia in clinical practice is really variable. Areas which have a good specialist, if I talk about type 1 diabetes, areas with a good specialist type 1 service, strong structured education and high access to technology will actually have quite lower rates of hypoglycemia, I think, certainly for type 1, than other areas with high social deprivation, low access to structured education and low penetration of technologies. So I think actually over the years, the variation between areas in hypoglycemia prevalence has increased as variation in access to these things has increased. So published studies obviously usually exclude those patients who have the highest rate of hypoglycemia, and those with the highest rate of severe hypoglycemia are often the people who don't access healthcare. So I think in that perspective, the published rates, there's probably a more breadth across the rates of hypoglycemia that you see in published data. As we've got an increasingly aging population who are accumulating more comorbidities, I think this is an increasing problem. The data, to my knowledge, suggests that more people are admitted to hospital with hypoglycemia type 2 diabetes than type 1, and there's a huge growth in the people over 70 years of age. Lovely data from Kamlesh Kunti. I think, however, in the last year or 2 years, there's been a shift to identifying those people and maybe looking at age-appropriate targets. But at the moment, it's actually for the NHS, it's probably a bigger problem than hypoglycemia in type 1 diabetes, which actually is more of a problem for the people rather than the health service. Awareness of the problem and of the risk factors of people who are at high risk. I think that's the key thing where there needs to be more work done. There are some predictors out there, but I think we need to know a little bit more and understand that a bit more. And then, in the era of personalized medicine, I think, developing more simple algorithms that maybe primary care physicians can work out to de-escalate therapy, to make hypoglycemia specific provisions in those people. And for type 1 diabetes, I think the push today, there's been some new Libre guidelines announced that allow use for this better technology in the type 1. So I think those are the two, in type 1 and type 2, two different pathways to reduce the burden of hypoglycemia that we have today.